Dear all, in this video, I shall be discussing about retropharyngeal abscess. This is defined as collection of pus in the retropharyngeal space. The anatomy has already been described. The abscess can be classified as acute and chronic retropharyngeal space abscess. The basic differences between acute and chronic are: acute abscess is common in children below 5 years of age, whereas chronic may affect any age group. The cause of acute retropharyngeal space abscess is suppuration of retropharyngeal lymph node of Rubier penetrating foreign bodies like fish bones and post-traumatic or post-surgery in the tonsils or in the oropharynx. Causes of chronic retropharyngeal space abscess are tubercle infection of retropharyngeal lymph node, which may occur at any age, caries of cervical spine due to tuberculosis, so-called Pott's spine, and either post-trauma or surgery in the cervical spine or in the oropharynx or sometimes in the neck. Important question in the Viva: why is acute retropharyngeal space abscess common in children? The most common cause is suppuration of retropharyngeal lymph node of Rubier, which is common in children below 5 years of age. The node subsides after 6-7 years. Therefore, acute retropharyngeal space abscess is common in children below 5 years of age. Now coming to acute retropharyngeal space abscess, the symptoms are history of upper respiratory tract infection because the child has infection of retropharyngeal lymph node. The child will have dysphagia, that is difficulty in taking foods, maybe difficulty in breathing or noisy breathing because of compression at the oropharyngeal level. Croupy cough and torticollis because of pain. The child will be ill looking, febrile, and there will be drooling of saliva because the child cannot swallow properly. The child will have hyperextension of the neck and head so that more amount of fluid or more amount of pus can be retained there. If the child flexes the neck, then there will be difficulty in breathing. The voice will be like hot potato, like muffled voice because of compression on the oropharynx. There may be neck swelling and tenderness, but most of the times neck swelling is uncommon. On examination of oral cavity, we can see a bulge on the posterior pharyngeal wall, which is usually unilateral. In the anatomy, you must have discussed the retropharyngeal space is divided into two spaces. They are space of Gillette by the midline raphe. So if it is true retropharyngeal space abscess, the pus will be localized in only one space. So there will be unilateral bulge in the throat. This is also commonly asked question in the university examination. The difference between pre-vertebral space abscess and true retropharyngeal space abscess. In pre-vertebral abscess, the pus will be in the midline or there will be bulge in the midline, not in one side. The laryngeal crevice will be absent and there will be positive tracheal rock sign. Laryngeal crevice is present because of the laryngeal structures sliding against the prevertebral fascia. So if there is pus in the retropharyngeal space, there will be no laryngeal crevice because pus will be obliterating the distance between the laryngeal structures and the prevertebral structures or fascia. Tracheal rock sign will be positive. If you move the trachea side by side, there will be pain, that is called positive tracheal rock sign. What investigations will be carried out for the diagnosis? Complete blood count is performed to look for septicemia. Plain X-ray of the soft tissue neck lateral view is the most important investigation to be carried out in patients with suspected retropharyngeal space abscess if there is no CT scan available. On X-ray, at the level of C2, the distance from the anterior border of the cervical vertebrae to the posterior border of the airway should be less than 7 mm regardless of the patient's age in all age groups. At C6, it should be less than 14 mm in children younger than 15 years and up to 22 mm in adults. Widened prevertebral soft tissue shadow more than normal in all ages, or more than 2/3 of corresponding cervical vertebral body, or presence of air fluid level signifies retropharyngeal space abscess. More than 2/3 or presence of air fluid will be the better choice in clinical diagnosis. CT scan of neck, both plain and contrast, is the most important investigational choice. It helps us to find out the extent of infection or abscess and involvement of other spaces. As you know, there are other different spaces, so the infection can spread from one space to another. So we can find out if the infection has spread from one space to another space with the help of CT scan. Therefore, if available, CT scan is the better choice than X-ray. After diagnosis, we need to treat the patient. As I already told, there will be dehydration, so give adequate hydration by IV fluid supplementation. Systemic antibiotics against gram-positive, gram-negative and endemic infections are to be given to control the infection. The antibiotics like ceftriaxone, metronidazole, amikacin can be given. But before that, we have to do complete blood count and blood urea creatinine kidney function test. If KFT is deranged, then amikacin is to be held because patient may be in kidney injury also. Patient may have dehydration. The pus should be undrained, can be performed by transoral or by transcervical technique. The advantage of transoral technique is patient does not require anesthesia, but patient has to lie supine with head low, and we need to incise the abscess and pus is to be suctioned. Patient has to be in supine position with the head low so that there will be less chance of aspiration if the pus bursts out. Transcervical approach can be performed through lateral neck incision. When the abscess is high, then you have to go through the anterior border of the sternemastoid, and when the infection is in the low level, you have to go from the posterior part of the sternemastoid. So you need to know the level. But when there is abscess, when there is fluctuation, when there is swelling, then we can go through the swelling. The problem with the transcervical approach may be pharyngocutaneous fistula in the long run. If it is tubercular lymphadenitis, so we should avoid the neck incision if possible. If the patient has respiratory distress or if intubation cannot be performed, then tracheostomy is to be performed. But if possible, even general anesthesia with intubation is to be avoided because there may be aspiration of pus when the abscess ruptures during the intubation process. This is the picture depicting drainage of the retropharyngeal space abscess. The head lies below the table. This is the edge of the table. Head lies here, and incision is given here, and the pus is removed so that there is less chance of aspiration. Coming to chronic retropharyngeal space abscess, the clinical features are it is indolent in comparison to acute form. So patient may be dysphagic, but patient may take orally to some extent. Patient may be emaciated. Patient may have throat pain, dysphagia, and on examination, bulge can be seen on the posterior pharyngeal wall with fluctuant swelling. So maybe incidental finding while we do X-ray soft tissue neck lateral view. The lateral type is Cox infection of cervical lymph nodes spreading to retropharyngeal nodes and forming a cold abscess. So it goes more laterally because it arises from the true retropharyngeal space, that is space of Gillette. This is usually seen in children below 5 years of age, and on examination there may be intraoral swelling, classically on the sides, which is fluctuant with minimal signs of inflammation. It's a chronic one. So if it's in one side, then you have to think of true retropharyngeal space abscess, and if it's in the midline, you have to think of pre-vertebral space abscess. In contrary, the central type is due to Pott's tuberculous cervical spine, so this is in the midline. Abscess presents between the body of vertebra and the pre-vertebral fascia. The swelling is usually in the midline, which spreads to both sides, causing diffuse bulge of the posterior pharyngeal wall and is fluctuant with less signs of inflammation, as it is tubercular origin. So to differentiate, the central type is due to Pott's tubercular spine and the lateral type is due to Cox infection of the retropharyngeal lymph nodes of Rubier. This may be asked in the exam. The investigations for chronic retropharyngeal space abscess are, as in acute retropharyngeal space abscess, to look for septicemia, the extent of infection, and the amount of infection. Jill Nelson stain of the pus after aspiration is performed to find out tuberculosis of the spine or tubercular etiology. Treatment is same by IV antibiotics, IV fluids, incision and drainage by peroral or external approach through the neck. If the patient is tubercular, then we have to give anti-tubercular treatment. So genuine stain of the pus is important. And the neck is to be explored to find out if there is any foreign bodies like fish bones or any foreign bodies that is causing the retropharyngeal space abscess. If the tubercular infection of lymph nodes or cervical spine is there, we have to treat that also by adequate surgery and debridement. There are certain complications of retropharyngeal space abscess. They are secondary to mass effect. There will be airway obstruction. There will be speech problem like hot potato voice. The abscess may rupture spontaneously or during the instrumentation, leading to aspiration, septicemia, or mediastinitis. Because as you know, the retropharyngeal space abscess can reach up to the mediastinum. Pre-vertebral space can reach up to the coccyx. The infection can spread to other neck spaces also. That might lead to multiple space infections. This is all about retropharyngeal space abscess. This topic is very important to you. This may be asked in the final exam as a long question also, in Viva as well as in the spotters. And this is very important for your practical day-to-day activity while seeing the patients in the OPDs. Thank you. If you like this video, please subscribe my channel Dr. Krishna Koirala for more videos like this, which are very important from your examination point of view as the recap. Thank you very much.